at probably the least challenging topic here, but put together some of the recent highlights. So let's just start out with this. This is the NCCN guidelines in May of 2024. Some of the things that are somewhat new is consider germline testing, genetic counseling, referral for younger patients, and that's something that I've started doing for the younger patients presenting with bladder cancer, and we've talked a lot about Lynch syndrome as well. And then for primary surgery after TURBT, gemcitabine, I'm very happy to see the preferred parentheses there, or mitomycin. Many of us as urologists have switched to gemcitabine because of mitomycin, the idiosyncratic reaction you can get that's really terrible and can lead to really miserable life for the patient for the next 6 months or 8 months, and it's completely idiosyncratic. So most of us, I think, use gemcitabine. And then I'll go through the rest later, but this is kind of what the bladder might look like after a single dose of gemcitabine perioperatively. All of us have cases that we can recall, and ulcers, and if this gets outside the bladder, then the entire retroperitoneum and peritoneum can, I see all nodding heads around, so it's terrible. So I don't use mitomycin at all. Okay, so not a whole lot of change here. You see the grade distribution there and the AUA risk factor. So within the NCCN guidelines is basically the AUA guidelines kind of, and I want to highlight this part, which is high-grade urothelial carcinoma actually falls in the intermediate risk for TA tumors that are less than 3 centimeters in solitary. A lot of controversy. We've had lots of discussions at IBCG, the International Bladder Cancer Group, and various others. EAU considers all high-grade TA tumors high risk, but there's this, category that we currently in the AUA guidelines have as intermediate risk, and this has implications on trial inclusion because the trials that are meant for intermediate risk patients will include this. Although we're prioritizing bridge for these patients, we're kind of treating them as high risk, and yeah.
I'm sorry.
No, not at all, please.
I say something. I know I'm interrupting your talk.
Please.
But I feel if I wait until the end, we'll go into other conversations. I just want to, I know this has been in the literature, like historically, the path literature has been removing this. This T1 low-grade urothelial carcinoma is not an entity. We and others have done studies that when you find these cases, they behave like typical high grades. And if you go back and look at those cancers, we looked at every case diagnosed like this at the Cleveland Clinic, there's always some high grade. So it's one of these low grade with focal high grade features. You can always find high grade if you look carefully in those. So I feel like it keeps getting perpetuated in these guidelines. But if you ever get this, don't be like I was just a low-grade patient with invasive disease. Those are high-grade cancers. I just wanted to say that, and I know you don't.
Thank you very much for bringing that up. We've had vigorous discussions at IBCG most recently about this exact, and some of your colleagues are there. And so this perpetuated, unfortunately, like you said, it just keeps getting added on. All of us as the expert urologists, I think, don't look at this. We think it either doesn't exist, or if we see it, there's some question, and we most likely, but you're right, in the community, if they see this, they might treat it like a low-grade tumor. The other one is sort of nested variants, but you see all the variant histology or the subtypes, histological subtypes are obviously high risk. Okay, again, these are NCCN guidelines. So you have the risk categorization, and you have the very high risk. Within the high risk patients, you have the very high risk features, and you can see that cystectomy is preferred. Those are patients with variant histology, and I'll go through that. Or BCG. A BCG still can be used, and if you don't have very high risk features, BCG is preferred. And then if you have BCG unresponsive disease, you have a variety, and this is where discussions are getting a little bit more complicated within our clinics, because we can either go to cystectomy, which is still preferred, here, even though perhaps we have a lot more options: intravesical chemotherapy, or pembrolizumab, or nadofaragene, or nogapendic and becacept, otherwise known as any out of three. I think I did it right. Okay, so we do have these options that have now made it into the NCCN guidelines, which is great. This used to be an empty box here. And we had valrubicin in there, which has notably been taken off now, which is great. Okay, Dan showed this yesterday, and I actually took a picture of it and put it right up there because it very nicely demonstrates the cis-eligible and ineligible. I'll go through each one of these. Now, my assignment was non-muscle invasive. I could have been done with my talk in 3 minutes, but I had to do some more slides. So I could have sat down just now. All right, so for diagnosis, there's a recommendation for molecular genomic testing, including RT-PCR for FGFR3. We've done a lot of discussion about that, but the HER2 overexpression is new. These are for higher stage patients, just because we now have targeted therapy for those patients. So this is for cis-eligible, stage 4. We've talked about this already, and I won't go into, I just highlighted some of the changes in the category. So EV-Pembro has obviously moved into a category A in the recommendation, the preferred regimens. And other regimens, Gemcis followed by avelumab. Maintenance therapy is a category 1, and Gemcis Nivo was a category 2A and has now moved into category 1. And the preferred regimens, docetaxel and VEC with growth factors followed by avelumab, is also a category 1. So there are options here, if for whatever reason patients are not options for EV-Pembro. And this is for cis-ineligible. Obviously, we prioritize clinical trials still, but EV-Pembro, obviously, again, category 1, moved from 2A to 1. And other recommended Gem-Carbo followed by avelumab. I'm still seeing this coming from the community. And then other useful regimens, single-agent Gem-Tax, paclitaxel, and atezolizumab for those who express PD-L1. And then the trastuzumab deruxtecan for HER2-positive IHC3+. So let's move to the AUA guidelines, which is similar. This was initially done in 2016. I was on the original guideline panel, but since then, 1,900 abstracts, 75 met inclusion criteria to be included, and not a whole lot has changed, actually, but I'll highlight some of the things that are very similar. I mean, this was a similar statement in the previous one. The non-muscle invasive bladder cancer biomarkers may be used to assess response to intravesical therapy. We've had some discussion. Eurovision FISH to adjudicate equivocal cytology, FISH and Immunocyte. I don't think anyone uses Immunocyte.
It's no longer produced.
Yeah. Why this made it into the 2023 updates, I don't know. I'll show you a slide after this. And then should offer blue light cystoscopy. We had that before, evidence grade B. The reason it got put up there again is because the photo trial was published showing no difference in progression, lots of issues with the trial. I'm not going to belabor the point, but it didn't change the strength of the recommendation. Still, there's a huge body of evidence showing the benefits, so it remained a grade B. NBI still continues to be there as a conditional recommendation, grade C. So nothing's changed there. I'm unaware of any good prospective studies on NBI. For variant histologies or histological subtypes, as I think we now should call it, Donna? What should we call this?
No, the WHO is trying to standardize terminology. So they went from using the term variant to calling them all subtypes, which is frustrating because in my mind, bladder cancer subtypes could be like squamous cell carcinoma, adenocarcinoma. So I'm not sure what we call those right now, because I used to call those subtypes. So yeah, it's just a semantics thing to try to standardize, but I think a lot of us still say variants.
Yeah. As these things go, whenever there's a change, sorry, Arlene.
So one of the challenges with the subtype term, we also use the term subtyping for gene expression profiling.
Yeah.
So I find that somewhat confusing. I don't know if there's a better term that could be used. to distinguish it from RNA expression. We should call it variant histology. Variant histology.
Yeah, I know. It's like some of the standardization is really just a big mess that they do. And the nice thing like that I thought was good about variant is like we're saying these are like variations of urothelial carcinoma, like derived from that, maybe associated with that conventional form, versus like a pure squamous, a pure adeno, for example. I don't know. Like this is maddening when, they make these decisions just for a book and a terminology, and they're like, we're making things better because we need to change things because we have a new edition, and then you get this, which is like not useful.
Phenotypic features.
Of course, it took 20 years for people to recognize the term variant histology in the community. Now we're going to change it and confuse everyone. So,
Question.
Yeah.
How you use the upfront cystectomy for variant? Is the matter like a 2%, 3%, 10%, or how you do?
yeah, we just had a meeting on histological subtypes, and because your colleagues were there and were pushing the term, but there was no consensus on percentage. From what I understand, there are really no good studies. And when we have done studies, for instance, we did a study on micropap, and the percentage of micropap did not matter. Now, 2% is probably different than 98%, but when we looked back at cystectomy specimens and looked at the percentages of micropap, it didn't matter. Stage for stage, they were the same. Obviously, this is non-muscle invasive. It portends for a higher stage at cystectomy or other. It's a predictor of upstaging. But as far as I know, there's really no good study to show the percentage matters.
Yeah, I mean, I think going back to that McKinney study I mentioned, and sometimes it's easier to even show with pictures because it's like such obvious differences that you're like, oh yeah, I get that. I'm a very conservative person when it comes to calling micropapillary, so the histology is just anyone could recognize it, right? And those tend to be much higher percentage, of that morphology, like really prominent retraction artifact, like it really fits the definition. And there's a whole range of gray below that some people call everything, even if it's like slightly retracted, even if it doesn't quite fit micropapillary. And so if you put these all in a bucket, like it makes sense that if you look at a whole group that was diagnosed, it probably doesn't have much difference. If you called out some of those very classic conservative patterns, I think those behave much more aggressively. So, the trick is who's doing the study, what's the histological criteria that you use, where that threshold, again, where are you drawing that threshold, I think makes a difference. But, if you're grouping everything together and just saying anyone called micropapillary, that morphology can be really quite different. And, I'll say in here too, like upstaging and variant histology, if you think about squamous, depending on how you call that, you can start to see squamous changes before you ever get like keratin pearls or keratin formation. Those typically are more the pure squamous cell carcinomas once you get to that point. Much more like head and neck cancers, you get clear cell change, like bizarre giant cells, et cetera, with it. But you could start to see cytoplasmic change with these intermediate filaments, like pinking up of the cytoplasm. Some of the criteria more used in cytology, and if you use those criteria, that's 40% of cases. So the question is, how different really is that from conventional urothelial? Like, it's again, where do you draw that threshold, right? And I think it's hard because it's a range. The histology is never like a textbook, right? It's a range.
But you have to realize again that, we're talking about tumor types that make up 1% of most bladder cancers, right? And the vast majority of small cell, signet cell, plasmacytoid tumors are higher stage tumors. Almost none of us even believe we've seen a T1 plasmacytoid type tumor. So I think from a guideline standpoint, when you were now talking to the broad community on how to manage these potentially lethal higher risk tumors, this makes total sense, right? Now, there may be the standout small T1, wow, really? There was a little plasmacytoid called in that, maybe is different, but that is such an outlier, I think, from a broad standpoint when you're putting guidelines like this together. This seems like this makes a lot of sense.
And to make it even more complicated, the concordance between the TURBT pathology, even if you go straight to cystectomy, and the cystectomy specimen is not 100%, obviously. And so you lose some of those variants in the final specimen. Obviously, maybe you resected it, but they get neoadjuvant chemo, things change. So it gets complicated. And one interest of mine is, it's interesting what's in the lymph nodes when you do a cystectomy in patients with variant histology. The lymph nodes tend to be just regular pure urothelial. So if we're saying that's the more aggressive, how come those are not the cells that are going into the lymph nodes? So we don't know.
Some of the issue though is that, squamous metaplasia is not a risky variant, right? Some people look at a variant and it's definitely different than sarcomatoid and plasmacytoid and small cells. So, and that's still the most common thing you'll see is like a squamous metaplasia. You see it almost every woman, right? With tumor at the trigone. So, lumping them together and, and saying upfront cystectomy for a patient who happens to have some, we still need to be able to differentiate the types of variants and their aggressiveness, and not just, you can't just say everybody that doesn't have pure 100% urothelial is going to need to be managed differently.
Yeah, I think data is lacking. That's why it's expert opinion. We really don't have data here. And again, just a reminder, this is non-muscle invasive bladder cancer. So we're saying these patients, if you're going to do a bladder sparing, you should do a re-TURBT at least, because if you do have muscle invasive disease, for instance, in small cell, you're going to go through a neoadjuvant chemotherapy. And it's just a comment on the high rate of upstaging. That's why upfront radical cystectomy should be recommended. But again, expert opinion. And a lot of it stems from the fact that the clinical trials exclude these patients. They exclude any patient with more than 50% variant histology. But slowly, I think we're beginning to include some of those patients in some of the, at least, invasive trials. In any case, just a quick thing. I showed this at the SUO, the value of blue light. Obviously, we have some erythematous lesions here, but this is me resecting what I feel like is CIS, but 10% of those can actually have an invasive component, and I don't take just cold cup biopsies. And on the right, you can see the scrape test that I do, and where these are CIS cells essentially scraping right off, and that's a way to tell whether something is false blue positive or not. You can actually see the fluorescence there maintained. And just one study on adjudication of atypical cytology. I'm surprised this actually did not make it into the guidelines in the discussion portion of it, because there is a good study here led by Yair that CX bladder adjudicates 100% of the atypical cytologies. If you look at the patients who had CX bladder negative with atypical cytologies, none of those patients had urothelial carcinoma. So it is a good way to adjudicate atypical cytology, but somehow, I don't know why that didn't make it into the, I'm sure you'll go into more detail with this. But intravesical treatment, we went through this single postoperative installation of intravesical therapy, gemcitabine. Unfortunately, it doesn't have that preferred that you see in the NCCN guidelines. Perforation, obviously don't give chemo. And then this persistent recurrent, or basically BCG unresponsive, clinical trial enrollment, or again, these same drugs that you saw, nadofaragene, and alternative intravesical chemotherapies. I'm glad that's in there. Gemcitabine and docetaxel may be considered. And some of those approvals came after this amendment, after the meeting for the amendment. So you don't see it quite here. You see it in NCCN guidelines. That's why you don't have the additional one. And pembrolizumab has a conditional grade C as a systemic immunotherapy option here as well. Just a thing of interest here. Everyone's fascinated by this, that we have identified 17 patients just at our institution that developed alopecia with a single dose of intravesical gemcitabine. It's mind-boggling. I don't understand it, but obviously there's some systemic absorption. Since this, we opened it up to all the centers. We asked, have you ever had them? And we've had a plethora of people say, yep, I've had this patient, this patient. So we're putting together a case series of this alopecia, and some of them are severe. And I have pictures of women with their hair falling out and with a single dose, which doesn't even happen with IV jab. So I'm not sure what exactly is happening here. We can't quite explain it, but in any case, it is happening out there. Yeah.
Last slide, for the Pembro and the nadofaragene, it gets a 2C. Is that because they were single-arm trials and
Yeah.
they were smaller trials?
Yeah. Yeah.
I may ask you, have you seen any difference in outcomes in the patients that were still here? Or?
That's a good question. We have not compared them to the ones, but maybe we should, and maybe it might be better. Who knows? Better response, but obviously something's getting into in the systemic treatment, and because patients think they're getting chemo, they think some of the side effects that they have, they don't report to us because they say, oh yeah, after I got it, I was like super nauseous and fatigued for 3 days. We're like, what? That's not part of, our TURBT. So obviously there's, yeah.
Are you seeing it mostly in women?
No, we've seen it in men too. Now women, it's much more noticeable in
Yeah.
women. The men, we've started asking them now. And they're like, oh yeah, I lost a little bit, but you gave me chemo, right? So the men are thinning hair anyway. It's harder to tell, but and they think it's normal. So it came to my attention when someone called me and said, my hair's falling out. I was like, what do you mean?
Yeah, we can see hair loss from systemic gemcitabine.
Yeah.
It's not
not
as
that
significant typically as something like dose-10-Semvac. And there can be systemic absorption. I've seen patients over the years who've had intravesical gemcitabine. The one most recently had a neurogenic bladder and probably was not excreting the gemcitabine and had more sustained uptake. He also had a lot of diverticula, and he came in and was thrombocytopenic, and it improved, and then it happened again with his next intravesical, and it really appeared tied to the gemcitabine.
Yeah, I've seen thrombocytopenia as well. Again, we don't check because when they undergo TURBT, we never do a CBC afterwards. But it's interesting. So I just put that up.
How long does that usually go on for, that hair loss?
Months. I mean, I tell them it gets better, and I see them the next time, and it's better. I had one woman wear a wig for 3 months. Yeah.
So, yeah, I've seen that with women getting gemdosi. And one of my patients told me she did some research, and docetaxel is associated with that potentially. So my question is, when we give gemdosi and we see hair thinning in women especially, is that gemcitabine related or docetaxel related?
I don't know. So these are all single perioperative. This is so because the much higher rate, obviously you've denuded the epithelium where you're in the deeper layers of the bladder. I think systemic absorption is more. But I have heard also that during induction treatment or maintenance therapies that patients have had this. The case series that we're putting together does include that. It's going to be a very detailed description of all these patients. We have over 25 patients. So if you have them, please. That would be great. We're still open to that. So we can send you a very simple CRF, and it's very, very simple. And we'd love to have more. I think this should be out there.
My clinical perspective of hair loss is dose-10-Semvac is the worst.
Yeah.
Nearly everyone loses nearly every hair. Occasionally you have some that retain hair. The taxanes are next. We see much more hair loss with the taxanes, but we also see it with gemcitabine, but it's probably even less with that.
Yeah. Okay, I think we talked about radical cystectomy, and then some updates in muscle invasive bladder cancer. I think we all know this, cisplatin-based neoadjuvant chemotherapy. Those who have not received cisplatin-based neoadjuvant who have PT3 to 4 or N+ disease at cystectomy should be offered adjuvant cisplatin-based chemotherapy or adjuvant immunotherapy, i.e. nivolumab per checkmate 274. And those who've received prior chemotherapy, cisplatin-based chemotherapy, who have PT2 to 4 or N+, should be offered adjuvant immunotherapy. We've done a little bit of a deeper dive into the YPT2s and see whether they get the same benefit as a YPT3 and 4s, but more data to come later. All right, prostate and seminal vesicles in males should be removed adjacent to reproductive organs in females. That's a clinical principle. However, organ-sparing procedures, especially in women, should be considered based on disease location and characteristics on an individual basis. So we're doing a lot more female organ-preserving cystectomies in patients who don't have disease in the posterior bladder wall and really have anterior or sort of anterior lateral wall. You have to be really, really careful. I think everyone in this room obviously knows because that bladder is sort of completely plastered to the vagina, and separating it, you may, if you have even a T2 tumor, you can leave tumor cells behind, and positive margin is essentially almost a death sentence. And then a lymph node dissection, I think Bernie's doing a whole talk on that, so we'll carry on. Trimodal maximal TURBT should be done prior to chemotherapy combined with external beam. And plant cystoscopic surveillance obviously should be performed, grade B. And then bladder preserving therapy, we should be doing regular CT scans and cystoscopies and cytologies. So I think that's about it. Thank you.
Great, thank you.